All right, we'll go ahead and get started. Hi, everyone. Thanks for joining us and welcome to today's Present Approaches to Testing webinar on metagenomic sequencing, a tool for diagnosis of central nervous system infection. I'm Dr. Matt Binnicker. I'm a laboratory director in the Division of Clinical Microbiology at Mayo Clinic, and I'm the Chief Scientific Officer for Mayo Collaborative Services. Our presenter today is a colleague of mine, Dr. Robin Patel. She's the director of the Infectious Diseases Research Laboratory, a co-director in our clinical bacteriology laboratory, as well as a consultant in the divisions of clinical microbiology and infectious diseases at Mayo Clinic in Rochester, Minnesota. Just a few things to remind everyone of before we begin today. There's going to be a question and answer session at the end of the program, and you can submit any questions you might have online using the Q&A icon at the bottom of your Zoom screen. Please only use the chat function if you have any technical difficulties. We are going to be recording today's program, and that recording will be posted to our website in a few weeks. So now it's a pleasure to turn things over to our presenter, Dr. Patel. Robin?
Thank you so much, Professor Binnicker. It's a pleasure to be with all of you today and to talk about metagenomic sequencing of cerebrospinal fluid. Sequencing-based microbial diagnostics are really in their infancy today, but they have been evolving over the past several years. And really, if you look back historically over the past several decades. So this is a historical framework for sequencing-based microbial diagnostics. And I'd like to keep it in mind because I'm going to talk to you about the present today, but I think we'll also envision a little bit about what the future might look like. The structure of DNA was described way back in 1953, and there was a Nobel Prize awarded for that. And then finger sequencing was described in 1997, and again, a Nobel Prize was awarded for that. These discoveries didn't really directly enable the advent of new diagnostics, but technology is what is enabling us to deliver new diagnostics. The first capillary sequencer for DNA sequencing was introduced around 1996. Historically, at Mayo Clinic in Rochester, we began routinely sequencing the 16S ribosomal RNA gene of bacterial isolates in 1999. Now, that's 25 years ago, and that might not seem like much, but from an overall picture, the first genome was not sequenced until 2001, and yet we were doing this in the clinical microbiology laboratory before the turn of the century. That's pretty exciting. Sequencing-based diagnostics have also been applied to HIV for resistance profiling, and that has been a very important tool to help us in the HIV epidemic. The advent of new technology really moved forward with next-generation sequencing. And I show a major milestone in 2011, which is the availability of the Luna MySeq platform. And that's followed in 2015 by the Oxford Nanopore Technologies MinION device. These types of technologies enabled us to bring next-generation sequencing to the clinical microbiology laboratory. And so although these weren't developed as microbial diagnostics, they can really be applied in the microbial diagnostics field. And for example, again, sequencing the 16S ribosomal RNA gene, not just from bacterial isolates, directly from patient samples, routine clinical practice in 2017. And we also began routine whole genome sequencing of bacterial isolates for the purpose of clonality testing in 2017, so 7 years ago. Metagenomic sequencing, the topic of today's presentation, became commercially available around 7 years ago. I mean, there might be some slight variations on that. And the main focus areas have been detection from blood, particularly plasma, and cerebrospinal fluid, the topic of today's presentation. And then I mentioned HIV resistance profiling. way back at the kind of turn of the century. And now we're using sequencing-based diagnostics to look for cytomegalovirus drug resistance, hepatitis C virus drug resistance, mycobacterium tuberculosis drug resistance, and others. And of course, there was a huge proliferation of sequencing-based approaches to infectious diseases with the COVID-19 pandemic, where there was a lot of sequencing going on, not necessarily for individual patient diagnosis, but really to understand what was happening with the virus as it evolved and continue to do so. So today, I'm going to talk to you about metagenomic sequencing of cerebrospinal fluid and the history of that kind of diagnosis, as well as what we've been doing at Mayo Clinic Laboratories. Now, as I mentioned, when we began sequencing microbes, we began with a targeted sequencing approach. For example, if we're looking for bacteria, we might take an approach such as shown on the right-hand side, where we amplify out the 16S ribosomal RNA gene, conserved in all bacteria, and sequence that. We can use Sanger sequencing or next generation sequencing, as illustrated here, to do targeted interrogation. And that will tell us which bacteria are present, because this is a conserved gene in bacteria. You could use other genes as well. For example, you could use a conserved fungal gene, or you could use individual viral genes to do this. And so that can help answer questions as to which specific targeted type of microbe might be present in your sample. But look at the left-hand side. This is more of a metagenomic approach, where in the example shown here, it's just DNA. I'm going to show you that it gets more complicated when we start looking at RNA. But what we do with a metagenomic approach is we extract out our nucleic acid, in the example shown here, DNA, and we amplify everything in that sample, and then we sequence it. And so what we're going to be sequencing is obviously human, but any microbe that might be present as well. And so this enables a broader approach to diagnosis than a more targeted approach, such as shown on the right side. And this has been very exciting. So, for example, if we take cerebrospinal fluid, as in the case of metagenomic sequencing of cerebrospinal fluid, we can take that specimen and we can look at all the nucleic acid that is present in the specimen. So this is an example. We would sequence everything. We would sequence all the DNA, and I'm going to show you the RNA as well. And the reason why we need to sequence the RNA is because there are some viruses that are RNA viruses, and we'll miss those if we're just looking at sequencing. So by taking this really broad approach, then we can look for bacteria, we can look for parasites, look for fungi, and then we can look for viruses, both DNA viruses as well as RNA viruses, in whatever specimen we're looking at. And for today's presentation, we're talking about cerebrospinal fluid. So this is exciting. So a metagenomic approach for infectious diseases diagnosis from cerebrospinal fluid allows us to look for potential pathogens without the bias of having to think about which type of organism this might be and ordering a specific diagnostic test. So we can look for DNA viruses, bacteria, fungi, parasites, and RNA viruses in the sample. Now, of course, this is contingent on the organism's nucleic acid actually being present in the sample that we're looking at, but it really opens the door to being able to ask very open-ended questions. So is this useful? Does this work? What do we know about it? I will say, as I showed you at the beginning with my timeline, we are in the early days of using next generation sequencing based diagnostics for infectious diseases. So we're learning. Not a day goes by that I'm not learning something, that the field isn't learning something. But if you look back 10 years ago, this study was published in the New England Journal of Medicine, and I think it makes a nice case for how this might be used. So the title was Actionable Diagnosis of Neuroleptospirosis by Next Generation Sequencing. And it was really a case report. A 14-year-old boy with severe combined immunodeficiency syndrome had presented 3 times over 4 months with fever and headache. And he had progressed to having hydrocephalus and status epilepticus, necessitating a medically induced coma. So this was a very sick boy. They had done an extensive workup that was unrevealing. They even took him brain biopsy. And I think that's important because infectious disease is sort of one of the definitive diagnostic approaches that one uses is to take biopsy of the involved area. But note that that biopsy did not reveal the answer. Now, I'm not saying we wouldn't want to do a biopsy in appropriate situations, but sometimes when we do a biopsy, and we've had this experience in our own practice, we don't find the etiology of what's going on in the patient. So we need even more than that. So what they did in this study is they did metagenomic sequencing of the cerebrospinal fluid, the type of assay that I'm going to talk to you about today. Now, I think it's important to look at what was actually found. So they had a total of 3,063,784 reads, of which 475 were from a microorganism called Leptospira species. That's a bacterium. Note that that's only 0.02% of the reads. So, when you're doing deep sequencing, you're sequencing a lot of off-target sequences that aren't giving you an answer. So this is where this gets complicated and where we obviously have to use next generation sequencing. Now, Leptospira can cause a central nervous system infection. It's not, well, at least we think it's not very common in the United States. I think it may be actually more common than we think. But it's importantly a bacterium and it's treatable. So that's why the title of this publication was actionable. Did confirm this diagnosis through orthogonal testing. And what that means is that suggests that this might be what's going on, but confirmatory testing is really helpful to know for sure. And so they did specific PCR and serologic testing. They confirmed a diagnosis of neuroleptospirosis. So this is exciting. This poor little boy had really an unsolvable issue, which was solved by getting the clue from metagenomic sequencing. Fast forward another 5 years. This is another study published by the same author, New England Journal of Medicine, and this is the results of the Precision Diagnosis of Acute Infectious Diseases, or PDAID study. This was a one-year multi-center prospective study of hospitalized patients who underwent metagenomic sequencing of their cerebrospinal fluid. The positive test study were confirmed by orthogonal testing, like I described in the leptospirosis. There were 204 pediatric and adult patients, and overall they were considered to have meningitis in 70, encephalitis in 130, and myelitis in 4. Note that there were some false positive results. They detected Pantoia species, Staphylococcus aureus, and Streptococcus agalactiae. Now, this is important. Remember, we're carrying out deep sequencing of a specimen. Cerebrospinal fluid, as you likely know, is collected by puncturing the skin and collecting the fluids. And the skin is not a sterile specimen. Also, when the specimens are handled, there can be the introduction of microbial nucleic acids along the way. And this is an ultra-sensitive technology to find organisms. So it's not surprising that you can have some false positive results, and that's what was reported here. So like any test, these results have to be interpreted in the context of what's going on with the patient. So what did they find? They found 58 central nervous system infections in 57 patients. And the details of what was found, I think, are really helpful. In 19 cases, metagenomic sequencing confirmed a diagnosis that was already known, so it enabled a concurrent diagnosis. In 13 cases, 22%, infections were found that had not been identified by routine clinical testing. What were these? Candida tropicalis, Epstein-Barr virus, echovirus, Klebsiella aerogenes, Enterococcus faecalis, hepatitis E virus, a polyomavirus, Neisseria meningitis, Nocardia farcinica, St. Louis encephalitis, Streptococcus agalactiae, and Streptococcus mumps. We'll talk more about individual organisms later on. But also note that in 26 cases, infections were not identified by metagenomic sequencing. And that might be surprising, but recall that you have to have the nucleic acid of the organism present to be able to have test work. And so how were those diagnoses established? Well, 11 were made by serologic testing. Now, this brings up an interesting point. Timing may matter. So cerebrospinal fluid is collected at a point in time in a patient's illness. And an organism may be there at a particular point in time and then disappear, but still have caused the disease. And then there's an immunologic response that's better picked up by a serologic test. So timing can make a difference. 7 were diagnosed from samples other than cerebrospinal fluid. So imagine that the organism, for example, is present in brain tissue, but not so much in the cerebrospinal fluid. Well, that makes sense. And then 8 were negative owing to low pathogen titer in cerebrospinal fluid. And how did they know that? Because they could see the nucleic acids of the pathogen in the test, but it was below what they would call positive for the particular test. This was another study published 3 years ago that was a literature review of metagenomic sequencing of spinal fluid in pediatric patients with meningitis and encephalitis. And I think it's helpful too to look at what was found across this literature review. I highlighted in red some of the organisms that might be perhaps a little bit surprising, or some that you might expect to find with this kind of test that you wouldn't necessarily find with routine diagnostics. Although, we can argue about which ones those might be. So you note that there are a number of bacteria, including Leptospira, as I already described that case, ureaplasma, parvum, interesting, mycoplasma, and then a number of viruses: adenovirus, chikungunya virus, mumps virus, West Nile virus, St. Louis encephalitis virus, a polyoma virus, a Bunya virus, BK virus, hepatitis E virus, and parvovirus B19, but also some novel viruses, a novel orthobunya virus and a novel densovirus. So again, you'll see also on this list parasites and fungi. This is a very broad diagnostic approach, and those can be found potentially as well. Now, I thought I'd also share results of this study. This came out of UCSF, and they have been performing metagenomic sequencing of cerebrospinal fluid for several years. This is from an article that's a preprint right now, and I put the link to access this, and this is where this information came from. So they described their experience between June 2016 and April 2023, testing 4,828 specimens. And I think it's helpful to take a look at this. First, you see the test volume that varies from 116, a little over 1,000 a year. And then you see the positivity rates. And you can see that that's a little bit higher in year 1 and then sort of settles down. And I'll show you some more detail about positivity rates. I suspect that's one of the questions that you may have. So this is the detail. Here they've broken down the total number of spinal fluids tested and then separated them by patients from UCSF and patients not from UCSF tested as a reference lab. And there are actually some very interesting differences between those two that I will highlight. First of all, the overall positivity rate, excluding possible or likely contaminants, was around 14%. That's actually where our data sits as well. So that's, I think, a helpful figure to be aware of. If you take a look at this, you'll see that the positivity rate was just a little bit higher, though on the borderline of statistical significance, from the in-house patients compared to the reference lab patients. And then you can see what was detected. So among the positive results, we have 3% detection of bacteria, 7% detection of DNA viruses, 4% detection of viruses, 1% detection of fungi, and less than 1% detection of parasites. And I'm going to show you some more detail about this in just a minute, because I suspect you have some questions about what exactly was being detected. But also note that there were sub-threshold results, meaning, as I described before, there was a potential pathogen, but it was below the threshold for reporting in 2% of cases. And note that this was higher in the UCSF patients compared to the non-UCSF patients. And that's because when you're looking at this data, it is just so helpful to know what's going on with the patient and have that clinical data in hand. And I found that as well in terms of understanding our own assay. And then what about contamination? As I already described, that can happen. So there was a single organism contamination in 3% of cases and multiple bacterial or fungal taxa in 7% of cases. And I think those are important to keep in mind as well. You'll see that those are a little bit higher on the reference lab specimens compared to the in-house specimens, which is also interesting and suggest potentially that, again, having that clinical context can be helpful in interpretation, but also that careful specimen handling potentially can make a difference in terms of this kind of assay. So what did they find in that study? Again, I find it interesting to look at what was actually found. And this is very high level. I do refer you to that preprint if you want to see all the detail. The top three RNA viruses found were HIV, enterovirus, and vector-borne viruses. And that's consistent with our experience as well. And the top two vector-borne viruses were West Nile virus and Powassan virus, which is also consistent with our experience. The top six DNA viruses were Epstein-Barr virus, human herpes virus 6 and 7, cytomegalovirus, varicella zoster virus, and herpes simplex virus type 1. The top three bacteria were Streptococci, Mycobacterium tuberculosis, and Klebsiella. And the top four fungi were Coccidioides, Immitis, Posidacea, Aspergillus, Cryptococcus neoformans gattii, and Candida species. And the top five parasites were Toxoplasma gondii, Thalammuthia mandrillaris, Taenia species, Angiostrongylus cantonensis, and Acanthamoeba castellani. This again is consistent with our experience, although our experience is smaller with this kind of assay. I know some of you had questions about sensitivity and sensitivity compared to other diagnostics. So they actually looked at that in their USF patients, and they compared the sensitivity of the metagenomic sequencing approach to whatever was ordered clinically diagnosed central nervous system infection. And overall, the metagenomic sequencing assay had a sensitivity of 56.5%. The specificity was 98.8%. And again, you might wonder why the sensitivity is not 100%. And I explained that earlier, that there are infections that are only detected at a certain time. There are infections that are better detected using serology. And there are infections that are better detected using specimens other than cerebrospinal fluid, such as tissues, because they're localized, for example, to the brain. In contrast, the sensitivity of the clinically ordered direct detection assays that were performed on cerebrospinal fluid in this study was 44.8%. And so the metagenomic sequencing assay was more sensitive than other direct detection assays in cerebrospinal fluid, which is interesting to think about. And then they report their turnaround time, and they separated this for their in-house UCSF patients and their non-UCSF patients. And those values were 8 and 11 days, respectively. And so it was longer if it was sent in from the outside. I'm going to show you our processes and turnaround times as well. This, I think, is really helpful. This is a commentary on utility and robustness and where this kind of testing might be helpful. And they comment that they feel that it's particularly helpful when routine testing fails or falls short. And they call out 5 situations. And so I thought I'd highlight those. The first is non-culturable or difficult to culture microbes, such as Bartonella, Hensley, Trophriema whipplei, Borrelia burgdorferi, Leptospira species, Histoplasma capsulatum, Aspergillus species, Rhizobus species, Coccidioides species, Fusarium solani, and Histoplasma capsulatum. That makes sense. The second is vector-borne viruses that are not commonly tested for. West Nile virus, although we do have tests for that. Powassan virus, we also have that, but not everybody does. St. Louis virus and Cache Valley virus. The third is rare or novel pathogens, such as Thalammuthia mandrillaris, Acanthamoeba castellani, Naegleria fowleri, Toxoplasma gondii, Taenia solium, Yersinia pestis, lymphocytic choriomeningitis virus, and Trypanosoma cruzi. The fourth is outbreaks, and I thought this was interesting as well. So they were able to find a novel orthobunya virus in mosquitoes from Connecticut that's called Potosi virus. They also had CNS infection with the vaccine strain of the yellow fever virus in a transplant patient with encephalitis. And they were able to diagnose Fusarium solani meningitis associated with surgical procedures performed under epidural anesthesia in Mexico. And so these are maybe things that wouldn't have been suspected, but were able to be found and outbreaks identified. And then they comment on rule out infection. I'm a little less certain about this because, as I mentioned, the sensitivity isn't perfect. And so using this kind of test to rule out infection has to be done with caution. But I think in some cases where you're thinking about a non-infectious cause and you just want to make sure you're not missing something, with correct consideration of test performance, you could consider using this kind of test. So let me move on to talk a little bit about our test. This is our in-laboratory workflow. So for the folks in the laboratory, we take our cerebral spinal fluid and we subject it to lysis and bead beating and extract DNA and RNA separately. And so we have a separate workflow for RNA and DNA in this assay. And the reason for that is that we need the RNA workflow to look for RNA viruses. We spike in RNA or DNA to make sure that we're able to detect a microbe in that specimen as we go through the process. And for the DNA process, it's a little bit easier. We sonicate and fragment and then move on to library preparation. Whereas for the RNA, we have to convert that to cDNA. And then the cDNA and the DNA go together and go through next generation sequencing. And then that undergoes bioinformatic analysis. I know some of you had questions about how long this takes. This is a general overview of where we are today. Extraction takes about 2 hours. The preparation for sequencing takes about 10 hours. Sequencing itself is about 19 hours. And then running the bioinformatic pipeline and analyzing the results takes about 6 hours. We do remove some human nucleic acid because anytime we sequence a human sample, we have a lot of human nucleic acid. And while that could be interesting for some applications, and we can certainly get to that in the question and answer period, when we're just asking the question as to which microbe is there, it means that we're sequencing a lot of human nucleic acid at the expense of really what we're trying to look for. And so we remove human ribosomal RNA by targeting conserved sequences, pulling down that human ribosomal RNA. And that increases our on-target reads by 2 to 5-fold on average. So these are some pictures from the lab. I really want to thank the team who A, developed the assay, and B, runs the assay. It's complicated. This is pre-processing, this extract on a QIAGEN instrument. Here's a photo of RNA library preparation, then RNA cleanup and concentration, DNA shearing for the DNA aspect of it, and then DNA and RNA templation, synthesis, amplification, and barcoding, DNA and cDNA cleanup, concentration and normalization, pooling of our samples, loading onto our NextSeq sequencing instrument, sequencing on our NextSeq sequencing instrument. And again, this is next generation sequencing. So we use Illumina sequencing for this particular assay. And so we have our small fragments of DNA that each get individually sequenced and then subjected to our bioinformatic analysis. We distill our results into what I feel is a relatively easy to understand report. Hopefully you agree. So we comment specifically on whether we see pathogenic RNA viruses, DNA viruses, fungi, and bacteria. So this is an example of a report where what we found is Staphylococcus aureus DNA, but not any of the others. This is an example of a report where we would have found acanthamoeba DNA. This is an example of a report showing herpes simplex virus DNA, and an example of a report showing aspergillus DNA. And then this is a negative result that comments that we don't see any pathogenic DNA virus, RNA virus, parasite, bacterium, or fungus. So we've been doing this since the beginning of the year, and this shows the number of samples that we've tested, a pretty regular rate. We run 2 to 3 runs a week. So depending on the time the sample arrives to us, it takes us a few days to get those results out. Occasionally, we end up having to repeat testing. We try to avoid that. If there is any degree of uncertainty in terms of the result, that will happen, and that can delay turnaround time, but that's really not the norm. So this is a few days turnaround time to result, depending again on which day of the week the sample arrives to us. And what have we found? Well, interestingly, we found looks a lot like what's reported in the UCS study. So I thought I'd share some of this because I think it's really interesting to see this in comparison to what others have reported. This is sort of just a listing of what we found. And show you some cases as well that I think are helpful to share. So Bartonella henselae, Capnocytophaga canemorsis, Enterococcus faecium, E. coli, Fusobacterium nucleatum, Haemophilus influenzae, Histoplasma capsulatum, species, Listeria monocytogenes, Staphylococcus aureus, Streptococcus intermedius, Streptococcus group, Tinea, Toxoplasma gondii, like in the case I showed you, Candida albicans, Coccidioides, Immitis postacei, HIV, Poisson virus, West Nile virus, BK and JC virus, enterovirus, HSV, and Mpox. So let me show you some cases here because what we're really trying to do is difference for our patients and understanding how this could be used and what kind of answers could be provided or helpful. So this was a woman who had presented with stroke, right-sided weakness, and hemi neglect, and was diagnosed as having a brain infarct. But it was noted that she had fevers despite her stroke management, which was unusual. So an infectious diseases consult was placed. And it was determined that she actually had had fevers for 6 months prior to presenting clinically. And she also had 2 kittens. There was an MRA that was negative mycotic aneurysm, but echocardiography was consistent with mitral valve endocarditis. And her serologies for Bartonella were positive. She continued with significant encephalopathy and fever that was felt by the neurology team to not be fully explained by the stroke pattern that was seen. And so they ordered metagenomic sequencing on cerebrospinal fluid, and we identified Bartonella henselae. It was confirmed a diagnosis of Bartonella colitis, and she was able to be appropriately treated with antibiotics and improved. And the provider who received this result was very excited and intrigued to receive this result of the metagenomic sequencing of spinal fluid. This is another case. This is this past July, so not that long ago. It was a man from New Hampshire, and we had serology sent to us for Poisson virus, IgM, and that was negative. And his spinal fluid came to us for metagenomic sequencing, and we detected Poisson virus in his spinal fluid. So this shows a scenario where the molecular diagnostic can be positive ahead of the serology, again, depending on the timing of the infection. And it could go the other way, of course, depending on when that spinal fluid is collected. This is a man who's post-allogeneic stem cell transplant for peripheral T-sarcoma, complicated by graft versus host disease, who presented with acute onset shortness of breath, lightheadedness, fevers, and rigors. He was afebrile, hemodynamically stable, and rapidly developed hypotension, requiring transfer to the intensive care unit. He was noted by the infectious disease team to have a pet dog with a, quote, very high tendency of licking, and blood cultures were positive for Capnocytophaga canemorsis. And so they obtained an LP that actually, from the standpoint of cell count, glucose, and protein, was rather unremarkable, but keep in mind his status post-allogeneic stem cell transplant. His opening pressure, however, was high, and shotgun metagenomic sequence of his cerebrospinal fluid revealed Capnocytophaga canemorsis. So this is Capnocytophaga sepsis with central nervous system infection, and he was appropriately treated with meropenem. We also diagnosed Mpox-associated encephalitis in a woman with CVID and relapsing Mpox infection who developed seizures and had a lab showing elevated CSF protein, and we found Mpox using metagenomic sequencing of her cerebrospinal fluid. This is a case of a man with headaches and vision changes. He had Vexus syndrome and had undergone haploidentical allogeneic stem cell transplant. He unfortunately had poor graft function, adrenal insufficiency, and hypogammaglobulinemia. And he underwent an MRI that showed increased T2 signal with right posterior temporal, in the right posterior lobes, vermis, and left cerebellum. Run an LP that showed a cell count of 80 with a lymphocytic predominance. And his spinal fluid was sent to us for metagenomic sequencing and revealed Toxoplasma gondii, and he improved with treatment with trimethoprim sulfamethoxazole. This is a case of a man who came to the emergency department with 3 days of fever. rash, livedo reticularis, that had started a day after he came to the United States. And he had come from France. He was visiting Arizona after traveling to Spain. He didn't have any significant past medical history. He was febrile at 39.2, hemodynamically stable, and noted to have mild thrombocytopenia, lymphopenia, transaminitis, elevated CK, and inflammatory markers. While hospitalized, he developed a new headache, and he also reported some leg weakness prior to coming into the emergency department. He underwent a lumbar puncture that showed a neutrophilic pleocytosis. And so they were thinking West Nile, but his West Nile virus serology at the time was negative. His CSF was sent for metagenomic sequencing, and that revealed West Nile virus. So this was helpful in making the diagnosis in that case. And then finally, this case, which I think is pretty intriguing. This is a woman in her 60s who had had 3 years of exercise intolerance, fatigue, nausea, vomiting, uh, followed by 2 years of progressive left side leg pain radiating from her gluteal area along her posterior leg. They didn't know what was going on. They gave her oral steroids and gabapentin to try to control her symptoms. Multiple spine MRIs were done. They showed an enhancing lobulated intrathecal process involving the thecal sac at the L5 to S2 levels. So they did an LP, and I think this LP is rather remarkable. The glucose was 7, the protein was 220. There were 21 white blood cells with 80% lymphocytes and 18% plasma cells, but an extensive microbiology workup was negative. That's not a normal spinal fluid by any means. So she had more LPs to try to get at the diagnosis, but still her workup was unrevealing, and she was referred to us at Mayo Clinic. We did a PET scan, and that showed localized radiotracer uptake at the site that was seen on the MRI, this enhancing soft tissue in the distal thecal sac. And she had an LP. So this is the fourth LP now, and that showed 118 total nucleated cells, 53% lymphocytes. The cytology showed a plasmacytoid appearance. The protein was elevated at 189. The glucose was less than 20. So again, really looking like an infection, but the microbiology workup was again negative. So this poor woman, right, going on for 3 years. She had a lumbar spine MRI that showed mild progressive enlargement over time of the lumbosacral enhancing intradural lesion, increased leptomeningeal enhancement, and a loculated appearance of the CSF with the term adhesive arachnoiditis used. So her history was fairly unremarkable. She was born and raised in Mexico, lived in the US, and she didn't have any pets. She didn't have any history of procedures in this area that was affected. She reported only having epidural analgesia during labor in 1997. But that's not really that unusual, and you wouldn't think that that would be associated with this kind of presentation so many years later. So this was really a big puzzle. So they sent metagenomic sequencing of her spinal fluid, and that revealed tinea solium. And so this was spinal neurocysticercosis, and that's a treatable condition. So she got high-dose steroids, albendazole and praziquantel, and she was symptomatically improved. So, you would think we could make this diagnosis in other ways, but this was a very unusual presentation, and the diagnosis was only made with this kind of testing. Now, I know several of you have questions about diagnostic stewardship and when to use this kind of test, and you probably know that I'm very big on diagnostic stewardship. And so one of the first steps, in my opinion, is coming up with a diagnostic algorithm for cerebrospinal fluid. So this is our diagnostic algorithm that we use at Mayo Clinic for cerebrospinal fluid workup. This was devised in consultation with infectious diseases and neurology, but it is really based on expert opinion. It's not necessarily, evidence-based, based on data from, say, a clinical trial, something like that. So this is what we recommend. And I think it's important to keep in mind, and I'll show you where this test falls then in the diagnostic algorithm. So this is the really for acute presentations. So some of the presentations that I showed you were less than acute, and we don't really have an algorithm for those kinds of cases. But we recommend, obviously, if you're doing a lumbar puncture, to measure an opening pressure. That's important. To do a cell count and differential, protein glucose, gram stain, bacterial culture. And if there is risk for cryptococcosis, a cryptococcal antigen, because we know that antigen can be more sensitive than a molecular diagnostic. And then blood cultures are also recommended. So this is really just run of the testing. We do have the meningitis encephalitis panel from BioFire encompassed in this algorithm, but also PCRs for herpes simplex virus, enterovirus, and varicella virus, as well as a pneumococcal antigen. And those standalone tests are actually preferred over the meningitis encephalitis panel in previously healthy patients. In those on prior antibiotics or immunocompromised, we would recommend the meningitis encephalitis panel from BioFire, or if you don't get an answer, with the standalone diagnostics. And then after that, if a diagnosis is not forthcoming and there's still a suspicion of infection, that's where we would recommend moving to the metagenomic sequencing of spinal fluid test. Now, I'm sure we can have a conversation about, whether this could be helpful performed earlier, and we just don't know the answer to that. So this is the approach that we take in our clinical practice at Mayo Clinic. And I'm going to wind up here. I'm sure there are some questions from the audience here. I really want to thank the folks who developed the assay that I talked to you about today and who run this every day. It's a complex assay to run. And as I mentioned, we're always learning. So I'm sure you have questions, and I'll try to answer them as we go into Q&A. So thank you much.
Thank you so much, Dr. Patel. That was a fantastic presentation and very informative. At this time, we'd like to take any questions that our participants might have. Just as a reminder, you can submit your questions through the Q&A icon that's found at the bottom of your Zoom window. So I see we've got one that's been posted so far, so I'll read that one for Dr. Patel to respond to. It says, in terms of response time, how beneficial is the sequencing assay compared to the most up-to-date MALDI-TOF equipment and databases in a clinical setting?
Yeah, no, very, very good question. So, we have a lot of tools that we can use to diagnose CNS infections. And so I don't believe that this assay is like the answer and the only test that you should be doing. MALDI-TOF, mass spectrometry, is a technology that we use to identify bacteria and fungi in the laboratory once they've grown up in culture. And it's very fast. It takes just a matter of minutes to get a very accurate answer. And so that tool is really used for something different. And as I mentioned, I believe that culture should always be performed. So therefore, MALDI-TOF should be performed once something grows up in culture to identify it. So it's not a question of one or the other. I think they can both have a role. But if you're trying to pick between, bringing shotgun metagenomic sequencing into your lab or MALDI-TOF mass spectrometry, it's probably the latter, because it's going to provide a lot more answers across a lot more clinical situations. But I think there are scenarios where this kind of assay that we discussed today can be useful in clinical practice as well.
Great. Thanks, Dr. Patel. So MALDI-TOF mainly used for rapid identification of culture isolates, whereas sequencing is maybe nothing's growing in culture and we have to cast a broad net and see what sequencing identifies. Thanks for that response. Another question in the chat is, what's the comparative sensitivity for bacterial identification between CSF metagenomics and broad range bacterial PCR and sequencing? Good question.
Yeah, that is a really good question. So at the very beginning of the talk, I sort of gave you the evolution of sequencing-based diagnostics. And one of the first approaches we took was to use a conserved bacterial target called the 16S ribosomal RNA gene to help us identify bacteria first in culture and then directly from clinical specimens. So we've been doing that from isolates since 1999 and from specimens since 2017 routinely in our clinical practice. And that is very helpful for direct identification of bacteria in clinical specimens. The difference between a metagenomic sequencing approach like I described and a targeted approach like 16S ribosomal RNA gene PCR sequencing is that the former can identify any kind of organism, so viruses, parasites, fungi, and bacteria, whereas the latter, if you're targeting the 16S ribosomal RNA gene, it will identify just bacteria. However, the question is, what's the relative sensitivity for detection of bacteria? Well, I will say that we haven't done that study for cerebrospinal fluid. However, we did a very large study looking at that exact question using another specimen type. In my research lab, we work a lot on periprosthetic joint infection. And one of the sample types that we work with samples the surface of implants for bacteria. And that's a kind of infection that is by far and away almost always bacterial. So we were really able to answer that question. And what we found is that the performance of the two approaches, so a 16S ribosomal RNA gene PCR sequencing approach using next generation, so I think it's important to incorporate that into that assay and not just Sanger sequencing, compared to metagenomic sequencing approach, were very similar. And so I would suspect that that's going to be the case for cerebrospinal fluid as well. But like I said, we haven't actually done that study.
Thank you. Another question for the patient who had C. kinemorsis identified from blood culture. Why was the metagenomics also done? Was it just a timing issue of the orders being placed?
Yeah, well, so that's one of those scenarios where I can't answer all the questions, and for sure there is a timing issue, right? So a lot of times you want to get everything ordered as early as possible, and then results are coming back, and so that may have been part of it. But I do think also, especially in immunocompromised types of patients, you theoretically have a bacteremia event going on and then some other central nervous system process. Yeah, how common is that? I don't know, but it's certainly possible. So in someone with a bacteremia who has something going on in their central nervous system, there can be scenarios where it's helpful to confirm that that's the same process that's happening in their blood as is happening in their central nervous system infection, because it can really help you know that you're giving the right therapy to that patient or managing them correctly for what's going on. But that's a very individualized decision. And it's a really good question, right? Like, when do you have enough information that you don't need to run this kind of test? And we have found scenarios where, as I described with the Bartonella case and the Capnocytophaga case, where this is really a confirmatory result. Like, if you looked at the other data, you might be able to ascertain that this was what was happening in their central nervous system as well. But sometimes we just need that additional confirmation to know for sure. And I would say, especially again, in these treatable infections where, we have specific antibiotics that can be used, knowing that answer and knowing you're on the right track and there's not something else that you're missing can be really helpful.
Yeah, thanks. That makes a lot of sense. I mean, the question brought up a good point that many might think about, which is if you have a blood culture that identifies an organism, can we just stop there? And what I'm hearing you say, Dr. Patel, is in some cases you may have the CSF infection be the same, but in other cases they may be different. And so just having an algorithm where if you identify it from blood culture and then canceling the CSF metagenomics may not be a good thing. You may want to either confirm or you might identify something else that's important.
Yeah, I mean, I really think you have to look at the individual case. And, in a case like that, I would definitely want to have an infectious disease physician involved in the management and really understand, do you think there's value to, proceeding with this additional testing now that you have this other answer that has been forthcoming?
Yeah, here's a kind of a follow-up question on this last thing that we've been discussing, which is a few of the case examples you presented demonstrated the same organism in both the blood and CSF. And so for bloody CSF taps, at what point do you think you're just picking up the organism from the blood versus in the CSF, and is a certain RBC count concerning?
Yeah, so this is a that's a good question as well, right? So, um, there can be bloody taps, potentially there could be nucleic acid in the CSF that's originating from the blood anyway, physiologically. And how do you know that the primary source is in the cerebral spinal fluid? I would say, I don't have a good answer as a laboratorian to that. I think you have to look at the whole picture and what's going on with the patient and see if it all fits together or not. In the cases I presented, they had evidence of a CNS infection, and it made sense. It fit together clinically nicely. But I do think you have to ask that question. Just detecting something is what I didn't talk about is like the contaminants. I mean, I showed you some examples of that from the UCSF data. When you detect something that doesn't make any sense, right? Like, why is it there? How did it get there? Do I do anything about it? What does it mean? Those can be complicated situations, and you really have to look at the whole picture.
Excellent. I don't see any other questions coming through the Q&A button. Just to wrap things up, I have one final one for you, which is you showed the algorithm where the CSF metagenomics fits in most cases after some more routine testing is done. I anticipate that'll be the case for a while, but do you ever see a day where we see these metagenomics tests being a more front line? And if so, what do we need to happen for that to occur?
All right. Well, thank you for that awesome question, Matt. As some of you might know, I'm really into diagnostic stewardship and thinking about how to use our tests correctly. And a lot of times when people think diagnostic stewardship, they think about restricting the test, which is fine, right? We need to use tests when they're appropriate. But the flip side of that is patients who could benefit from a test, making sure they get that test and making sure they get that test at the right time. And you can imagine that there could be an argument for, well, if this test is helpful, why would you want to wait to get it? Why would you not want to have that answer earlier rather than later? And, part of the answer is that we have pretty good diagnostics to figure out, for most patients, what's going on. And this is an expensive test. So, we don't want to start performing it on everybody, but it is a really good answer. And the answer to how we figure out the answer to your question, I would say, is taking an approach where we do a formal study of that. And our team has been involved in doing formal studies of the value of diagnostic tests. And so there are two ways to do those studies. One is to do pre-post type of study where you come from a way of managing patients that maybe doesn't involve that test routinely to one that does involve that test routinely. But that kind of study design can be flawed by other changes that are happening in the world, in medicine, and so forth over time. And so the perfect ideal way to answer that question is a randomized controlled clinical trial. Now, this is going to be tricky with this kind of test, but for other kinds of tests, it can be very useful. So we have done that with blood culture based diagnostics. So with multiplex PCR panels and rapid phenotypic susceptibility testing of positive blood culture bottles. And we just completed a study that was published in Lancet Microbe on the biofire pneumonia panel, because that's another one which is kind of an advanced molecular diagnosis, and we're not sure, whether doing it up front would make a difference. And I will refer you to that publication, which again just came out in Lancet Microbe, and it did make a difference in terms of antibiotic utilization, which we think is important. It would be lovely to have a study like that or be able to do that with a CSF metagenomic test. There are some challenges, obviously, in terms of numbers. It's, a bit of a numbers game. But if I had, my wish, it would be to have a clinical trial like that to really look at ideal utilization of testing for diagnosis of CNS infection.
Thank you so much. Very interesting, and yeah, it'll take time to generate the data, but I'm sure those studies are forthcoming. So I think we'll go ahead and wrap up. I want to thank everyone again for participating in today's Present Approaches to Testing webinar. on metagenomic sequencing, a tool for diagnosis of CNS infections. If you didn't get a chance to ask your question or it wasn't addressed, please include any questions you might have in your evaluation. You'll get a link in the chat to access that evaluation now. Laboratory credit is extended for this program, and upon finalized evaluation, you'll have that option to claim print your certificate. If you registered for the webinar and joined by phone only, please email mcleducation@met.edu if you don't receive that evaluation. So just final reminder, we did record this and it'll be archived on our website in a few weeks. So thanks again to Dr. Patel for the fantastic presentation and to all of you for joining us. Have a great rest of your day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.